Hello everybody and welcome to our module on hernias. A hernia is a protrusion of an organ through a cavity wall. The hernias we're going to talk about in this module usually involve herniation of loops of bowel through a part of the abdomen, and this can lead to organ dysfunction. It can lead to necrosis of tissue and infection. And in the abdomen, hernias are common in areas of discontinuity of the abdominal wall. This includes the inguinal canal, the esophagus, and the umbilicus. The idea here is that your peritoneum is a closed space, and when you inhale, the diaphragm moves down and compresses the structures inside the abdomen. This includes loops of bowel, which are all throughout the abdomen. If there is a hole in the wall, a loop of bowel can be pushed out through that hole, and that's called a hernia. Now, if the entire abdomen were continuous, there would be no holes for loops of bowel to protrude through. However, there are a couple of natural gaps in the abdomen. The first one is at the top. It's where the esophagus pokes through the diaphragm to enter the abdomen. Another natural hole in the abdominal wall is in the center of your abdomen. You have the umbilicus, and a hernia can occur there. And then finally, down in the legs, we have femoral vessels protruding out of the abdomen, and that creates breaks or discontinuities in the abdominal wall. And that is also where loops of bowel may be pushed out every time you take a deep breath and bear down and compress those contents inside of your abdomen. Before we talk about specific types of hernias, we need to review some anatomy, and I want to begin by reviewing the anatomy of the femoral blood vessels and the femoral triangle. You can locate the inguinal ligament and the femoral blood vessels by using two easy-to-find bony landmarks on a patient. The first bony landmark is the superior iliac spine, which is right about where I'm drawing with my pen right here on this picture. The second bony landmark is the pubic symphysis. This is the middle of the pubic bone where I'm drawing with my pen. A straight line between those two easily identifiable bony landmarks tracks the path of the inguinal ligament. If you look at the picture on the right side of the screen, this is the path of the inguinal ligament straight across the picture. Below the inguinal ligament, if you feel with your fingers right about where I'm drawing here on this picture, you will feel the pulsation of a blood vessel. That blood vessel is the femoral artery, and once you find the femoral artery by feeling for the pulsation, medial to that is always the femoral vein, and lateral to that is always the femoral nerve. Many people remember the order of those structures using the mnemonic navel. If you go from lateral to medial, below the inguinal ligament, you will first find the femoral nerve, then the femoral artery, then the femoral vein, and finally the lymphatics. Some people also like to remember that the venous is to the penis. If you look at this picture, this is a man's penis, and the femoral vein is closest to the penis. The femoral artery is further away. This area below the inguinal ligament is called the femoral triangle. Its upper border is the inguinal ligament, shown right here in this picture. Its medial border towards the penis is the adductor longus muscle, and its lateral border is the sartorius. These three structures make a triangle below the inguinal ligament, and within that triangle you can find all the structures in the navel mnemonic. If we were to stand just above the inguinal ligament and look down towards the foot of a patient, we would see the femoral structures in cross-section. It would look like this picture on the screen here. The most lateral structure would be the femoral nerve. That's the N in the navel mnemonic. Just inside of that, we'd see the femoral artery. That's the A in the navel mnemonic. That's the red structure in this picture. Inside of that, we'd see the femoral vein, which is the V in navel. And then inside of the vein, we would see something called the femoral ring. This is a circular structure that carries the lymphatics, which are the L in the navel mnemonic. Another thing we would notice if we looked at the femoral structures in cross-section like this is that three of them sit inside of a sheath of tissue called the femoral sheath. The femoral artery, vein, and the ring are all inside of the femoral sheath. The femoral nerve sits outside of that sheath on its own. Let's talk about the femoral ring in a little more detail. It is the opening to the femoral canal, and as I said before, it carries lymph vessels and also deep inguinal lymph nodes. It is a component of the femoral sheath. And this will be important later when we talk about femoral hernias, because femoral hernias are hernias that go through the femoral ring and enter the femoral canal. Now that we've reviewed the anatomy of the femoral triangle and the femoral vessels, let's talk about something different, and that is the inguinal canal. This runs across the femoral vessels parallel to the inguinal ligament. If we go back to this picture, the inguinal ligament runs like this, and the femoral vessels run below it in the femoral triangle. The inguinal canal runs on top of the inguinal ligament and courses in this direction. It carries the testicles into the scrotum. During development of the male, the testes descend through the inguinal canal into the scrotum. This is a picture of the opening of the inguinal canal here. You can see the spermatic cord coming out and entering the scrotum to carry the testes into the scrotum. So as you just saw, the spermatic cord travels in the inguinal canal, and the contents of the spermatic cord include the ductus deferens as well as arteries, veins, and nerves. There are three fascial layers to the spermatic cord, and this will be important later when we talk about types of hernias. The most external fascial layer is called the external spermatic fascia, appropriately. The middle layer is called the cremasteric fascia, and the inner layer is called the internal spermatic fascia. So the inguinal canal is a passage through the abdominal wall. This is a picture of it shown in the bottom of the screen here. You can see how it allows the spermatic cord to exit the abdomen and get into the scrotum. It carries the spermatic cord in males, obviously, as we've been discussing. In females, it carries the round ligament. And the entrance to the inguinal canal is called the deep inguinal ring, which is shown here in this picture. The exit of the spermatic cord from the inguinal canal is called the superficial inguinal ring, shown here. And then the floor of the inguinal canal is the inguinal ligament, and if you know that, it's an easy way to remind you that all inguinal hernias and problems related to the inguinal canal occur superior or above the inguinal ligament. Here's another picture to make this very clear. This is the inguinal ligament shown here. The deep, or it's sometimes called the internal inguinal ring, is where the spermatic cord exits the abdomen and enters the inguinal canal. The superficial or external inguinal ring is where the spermatic cord exits the inguinal canal to head towards the scrotum. Some other structures shown in this picture include the femoral artery and vein. Note that they are below or inferior to the inguinal ligament. Note also that the femoral ring shown here is medial to the femoral artery and vein. Also in this picture you can see the rectus abdominis muscle and the inferior epigastric vessels. These will be important later when we talk about landmarks for hernias. Now that we've reviewed the relevant anatomy, we can begin discussing specific types of hernias, and I'll begin by discussing the inguinal hernias. There are three types of hernias that occur in the inguinal region. The first type are called indirect, the second are called direct, and then finally there are rare femoral hernias. If we go back to this picture, this is the course of the inguinal ligament. The three types of hernias I just mentioned all present as a bulge in this area, and we're going to talk about the different causes and anatomy of those three types of hernias. I'll begin by discussing the indirect inguinal hernias, and these are by far the most common type of hernia in the inguinal region of the body. They are called indirect because the loop of bowel that herniates in this disorder herniates indirectly through the abdominal wall. The easiest way to understand indirect hernias is to recognize that they travel through the inguinal canal. They follow the path of the spermatic cord we've been discussing. They don't go directly through a breakdown or a hole in the abdominal wall. That's why they are called indirect. There are a couple of key anatomic landmarks you need to know about these hernias. The first one is that they originate lateral to the epigastric vessels. If we go back to this picture, these are the epigastric blood vessels here, and the origin of an indirect inguinal hernia is the deep or internal inguinal ring. As I said before, they enter this ring just like the spermatic cord. This means that they originate lateral to these epigastric vessels, and that contrasts them with other types of hernias we'll talk about in a minute. As I said before, they follow the path of descent of the testes. They track along with the spermatic cord. This means they are basically traveling along with the spermatic cord, and therefore they are covered by all the layers of the spermatic fascia. This is also a unique feature of indirect hernias. Direct hernias, as we'll see in a minute, have only the outer layer of the spermatic fascia. And finally, you should be aware that indirect inguinal hernias are a congenital defect. In this disorder, the bowel herniates and protrudes through a patent processus vaginalis. This is a structure present so that the testes can descend into the scrotum in the developing baby. It should close after descent of the testes. If it remains open, then you can potentially develop an indirect inguinal hernia through that patent processus vaginalis. Here's a nice picture showing an indirect inguinal hernia. A loop of small bowel has pushed its way through the internal inguinal ring, also through the external inguinal ring, and it is now herniating down into the scrotum in this drawing. Let me discuss the processus vaginalis in a little more detail because it's important to understand this structure in order to understand indirect inguinal hernias. In male development, the testes descend into the scrotum behind the processus vaginalis. They follow this structure down into the scrotum. The processus vaginalis is an outpouching of the peritoneum that descends into the scrotum. It will remain open in the newborn period, but then it should close or obliterate in infancy when it's replaced by fibrous tissue. And the remnant of this structure that you can find in the male is called the tunica vaginalis testes. This is a serous covering of the testes. To picture this, I want you to imagine some peritoneum growing down towards the testes in the male. Inside of it, the testicles will form, followed by the spermatic cord. This is the processus vaginalis, and it should seal around the spermatic cord and close off the possibility of bowel ever getting through it. If it remains open, then for the rest of that person's life, they have a risk of developing an indirect hernia. As I said before, this is the most common type of inguinal hernia. In males, 50% of hernias are indirect. In females, 70% of hernias are indirect. Although we've been talking about the inguinal canal and the spermatic cord, in women it carries the round ligament and hernias are still possible. These hernias are more common in men, as are all hernias. Men are 10 times more likely than women to develop an indirect inguinal hernia. They typically occur on the right side of the body. It's believed that a persistent processus vaginalis is more common on the right for unknown reasons. And commonly they extend into the scrotum, and this is easy to understand because they are following the path of the spermatic cord. Even though indirect hernias occur as a result of a congenital defect, the hernias themselves usually don't develop until adulthood. That's because it takes years and years of bearing down on the contents of your abdomen to finally push a piece of bowel out through that patent processus vaginalis. These type of hernias usually occur in adults who have risk factors where they bear down a lot. This may involve heavy lifting, or it may be straining from constipation. I've shown you a picture of a construction worker on the screen here to remind you of the classic type of patient to get an indirect inguinal hernia. This man could have been born with a patent processus vaginalis, but he didn't know it. He then lifts heavy equipment all day, and in his 30s or 40s he develops a bulge in his groin. You can also sometimes see these in newborn babies, especially if they are on mechanical ventilation. Mechanical ventilation can raise the pressure in the abdomen, and as I told you before, the processus vaginalis is patent in newborn babies. It closes in infancy. So here are the most high-yield points to remember about indirect inguinal hernias. The loop of bowel herniates through both the internal and external inguinal rings. It travels along the path of the spermatic cord and goes through the inguinal canal. It follows the path of descent of the testes in men, and in women it follows the round ligament toward the labia majora. In men, these hernias are covered by the spermatic fascia, all three layers. The origin is lateral to the inferior epigastric vessels, as we saw before, and then finally it's the most common type of inguinal hernia. Now let's talk about direct inguinal hernias. These hernias are called direct because the bowel bulges directly through a breakdown in the abdominal wall. People with direct inguinal hernias have a bulge through Hesselbach's triangle. I'll show you what that is in a minute. In contrast to indirect hernias, the origin of these hernias is medial to the epigastric vessels. The hernia goes through the external ring, but not the deeper internal ring like indirect inguinal hernias. It's covered only by external spermatic fascia, and it should never bulge into the scrotum. Let's go back to this picture here. What happens in a direct hernia is that there's a breakdown in the abdominal wall right here. As a result, a loop of bowel can protrude out through that breakdown, and once it gets outside the abdominal wall, the superficial or external ring is very close by, so the loop of bowel can protrude out through the external inguinal ring. Now, I told you before that indirect hernias also travel through the external ring, but there's an important difference. Indirect hernias are traveling with the spermatic cord inside the spermatic fascia and going through the inguinal canal. Direct hernias, like we're talking about now, are not traveling inside of the spermatic fascia. They are outside. They are simply bulging through the external ring as a result of getting through this breakdown in the abdominal wall. The defect in the abdominal wall that the bowel protrudes through in direct hernias occurs in Hesselbach's triangle. Hesselbach's triangle is formed by the inguinal ligament here, the inferior epigastric vessels here, and the rectus abdominal muscle here. You can see it makes a triangle. The floor of that triangle is called the transversalis fascia. This is a picture of the transversalis fascia on the screen here. This is it right here. I'm circling it with my pen. It becomes weak in direct hernias and breaks down, and a hole opens up, and then bowel can protrude through the transversalis fascia and then pop out of the external ring right here. Note that the origin of this hernia in Hesselbach's triangle is medial to these epigastric vessels here. That contrasts it with indirect hernias, which are lateral to epigastric vessels. So just to summarize, direct inguinal hernias are caused by transversalis fascia breakdown. This is a weakness in the floor of the inguinal canal, and this usually occurs in older men. It happens from years of stress on the connective tissue in the abdomen. It's sometimes called an acquired hernia to contrast it with the indirect, which are congenital. And this is a picture of an old man here to remind you of the type of patient that gets a direct inguinal hernia. The last type of hernia we'll talk about is a femoral hernia. This is where a loop of bowel herniates through the femoral ring, and we talked about the anatomy of the femoral sheath and the femoral ring before, and the femoral ring is medial to the femoral vessels. If we look at this picture on the screen here, this is the femoral artery and vein, and medial to that is the femoral ring where a femoral hernia will be. This is the only type of hernia where the loop of bowel protrudes below the inguinal ligament. In indirect and direct hernias, the bowel protrudes above the inguinal ligament. This type of hernia is more common in women and men, but don't get fooled and think that this is the most common type of hernia in women. It is not. Indirect hernias are the most common type for both genders, and this type of hernia carries a high risk of incarceration. That's because the femoral ring is a small opening. Inguinal hernias are usually easy to diagnose. Most of them are obvious on inspection of the inguinal region. There's a bulge in the groin. Sometimes patients are asked to cough. This temporarily increases the pressure in the abdomen, and it can increase the size of the bulge. Most people who have a hernia have no symptoms. They just notice the bulge, and that's why they come to medical attention. Sometimes, however, hernias can develop some complications that can lead to symptoms. The first complication is called incarceration. This is when the bowel is trapped in the hernia and you can't reduce it back into the abdomen or pelvis. When you meet patients with hernias, you can push the bowel back inside the body. If you're unable to do that, then we say that that hernia has become incarcerated. And incarceration is dangerous because it can lead to strangulation. This is when the blood flow to the loop of bowel is cut off, so the bowel in the hernia sac becomes ischemic and necrotic. When a hernia becomes strangulated, it will become painful and red and swollen. Patients often have a fever, and urgent surgery is often indicated. And as I said before, this is common in women who have femoral hernias because they travel through the very small femoral ring. As I told you before, these are usually diagnosed clinically, but you can sometimes use ultrasound or CAT scan to identify a hernia. This is a picture of a man with a hernia. Like I told you before, they're more common on the right, just as is shown in this picture. The treatment for all types of hernias is surgery. You can do a primary closure where you stitch the defect closed. There are also meshes that are sometimes placed into groin to protect it from further damage over time. Now that we've talked about all the types of inguinal hernias, let's talk about other types of hernias. Ventral hernias are hernias through the anterior abdominal wall. A loop of bowel protrudes through some defect in the anterior abdominal wall. There are many subtypes. Umbilical hernias are where a loop of bowel protrudes near the breakdown in the abdominal wall that occurs at the umbilicus. Incisional hernias occur through a site of an abdominal incision. Hiatal hernias are hernias that occur through the esophageal hiatus, which is the hole in the diaphragm where the esophagus enters the stomach. A hernia here will cause the stomach to herniate into the thorax. Now, all the hernias we've discussed up till this point in this module are external, so they are obvious as a bulge outside of the body. Hiatal hernias are internal, so you won't see a bulge, but patients develop symptoms from these hernias, and those are the symptoms of gastroesophageal reflux disease or heartburn. By having the stomach herniate into the thorax, the lower esophageal sphincter becomes incompetent and patients develop severe heartburn. And a major risk factor is obesity. It's thought that all the extra fatty tissue forces the stomach up through the esophageal hiatus and into the thorax. The most common type of hiatal hernia is called a type 1 or a sliding hiatal hernia, and this is where the gastroesophageal junction slides up through the hiatus into the thorax. This portion of the drawing here is the normal gastroesophageal junction, and you can see that it is above the diaphragm as indicated by this pink line here. The stomach is in its usual alignment. It's below the diaphragm with the fundus and the greater curvature where they normally should be. It's just that the junction is high up in the thorax. This will characteristically give an hourglass appearance on imaging of the stomach because the stomach is being pinched as it goes through the diaphragm, and it creates this hourglass shape to the stomach. There are less common types of hiatal hernias which are called paraesophageal, and they're called paraesophageal because a portion of the stomach fundus protrudes next to the esophagus up into the thorax. These occur as a result of a defect in the phrenoesophageal membrane. This is a membrane that should seal off the diaphragm so that the stomach remains below the diaphragm. If it doesn't seal properly, then this type of hernia can occur. And a classic finding is to hear bowel sounds in the lung fields. There's gurgling in the stomach that you can normally hear in the abdomen. If you hear that in the thorax, it suggests a portion of the stomach is protruding up into the thorax. The last thing I'll discuss in this module is a congenital diaphragmatic hernia. This is a developmental defect of the diaphragm. This occurs when there is in utero defective formation of something called the pleuroperitoneal membrane. This is a membrane that is supposed to seal so that you have a normal and complete diaphragm. If it doesn't form properly, there will be a hole in the diaphragm and abdominal organs will herniate into the chest. This is different from a hiatal hernia. Organs are not herniating through the esophageal hiatus. In this case, they are herniating through a hole in the diaphragm. The herniation usually occurs in utero. As a result, the lungs do not form properly because abdominal contents are present in the thorax. This is often a fatal condition when babies are born with this type of hernia. And that concludes our module on hernias.